procedures outside the operating room and judiciously allocated their dwindling stock of medical supplies. Like Montoya, the hospital staff used a set of rules to sort patients who required immediate care from those who could afford to wait. Treating traumatic injuries is difficult under the best of circumstances, and combat is about as far from ideal as you can get. The injuries are often severe, the physical conditions bleak. Medical staff work under the constant threat of assault, and critical supplies are limited. In 2004, the Army had about 50 surgeons in Iraq to serve 140,000 troops, as well as injured civilians and military contractors. Despite the challenges of medical care in wartime, by the beginning of the 21st century, combat mortality rates had fallen to surprisingly low levels. Only 1 out of every 10 American soldiers injured in Afghanistan and Iraq died of their wounds, well under half the mortality rate of soldiers wounded in Vietnam, and a world away from the 42% mortality rate of soldiers wounded in the Revolutionary War. This impressive survival rate is the culmination of continuous improvements in frontline medical care over the past 200 years. In the grim arms race between medical improvements and ever deadlier weaponry, the doctors are pulling ahead. Advances in drugs, surgical techniques, and diagnostic equipment are the obvious source of progress in survival rates. Also important, but less familiar to most people, are improvements in how armies allocate scarce resources in the face of mass casualties. Medical professionals are trained to do whatever they can to help the patient lying in front of them, but frontline medics, medevac pilots, and military doctors must make hard choices about whom to treat first. In the wake of an attack or battle, medics and admitting physicians are forced to make life-and-death decisions about complex injuries with limited information, under tremendous time pressure, and often under fire. Throughout most of history, the allocation of medical resources was haphazard. The poet Walt Whitman, who served as a nurse during the U.S. Civil War, observed that the injured were cared for on a first-come, first-served basis, regardless of the severity of their injuries. The wounded sat in line, waiting patiently for their turn to be seen by a doctor or nurse. After the First Battle of Bull Run, the injured who were able had to walk the 30-mile distance from the battlefield to hospitals in Washington for treatment, a system that failed those most in need of care, the soldiers lying on the battlefield. In the Second World War, the U.S. Surgeon General introduced a formal process for prioritizing care in order to reduce deaths. The system is known as triage, after the French word for sorting commodities, such as wheat or coffee beans, into categories based on their quality. Given the complexity of the injuries they encounter, you might think medics use complicated algorithms to classify the wounded. They don't. Instead, they rely on a handful of simple rules, like those employed by Montoya and the 67th Medical Staff, to quickly sort injured patients into 3 or 4 categories, prioritizing them for treatment. When performing frontline triage, medics will typically spend less than a minute with each patient. Simple guidelines, such as whether the patient can follow instructions, has a pulse rate below 120, or a respiratory rate between 10 and 30 breaths per minute, allow medics to quickly evaluate the wounded. The injured are then assigned a color-coded tag that categorizes them according to the severity of their injuries. Those with stable vital signs are tagged with the color green. Treatment can safely be delayed for these walking wounded. At the other extreme, patients who are unlikely to survive even with heroic intervention are tagged with black and provided palliative care. The remaining patients are first in line for care, with the more badly injured given a red priority tag and the others a yellow tag denoting urgent. Sorting the patients using these simple rules ensures that scarce medical resources are brought to bear where they can do the most good, on those patients who have a shot at survival, but only if they receive immediate attention. The rules of triage are widely used to allocate medical resources, such as intensive care unit beds or vaccines during a flu pandemic, in the face of mass casualties. After the Boston Marathon bombings, for example, a first aid center set up at the finish line was transformed from treating sprained ankles and dehydration